Okay, we should be live now.
All right, perfect. All right, we are live on Facebook. We will go ahead and we'll get started. We have individuals who have logged in to the this. Let's see, resume recording. All right, we have individuals who have logged in directly onto this webinar. We have individuals who are watching via Facebook. So once again, good morning, good afternoon, good evening. My name is Dr. Akwi Asambang. I'm the board president and co-founder of the Pan-African Organization for Health, Education, and Research. I am an interventional gastroenterologist, so not even close to being knowledgeable about prostate cancer. And so I did what most would do. I looked for the experts out there, and we have two fantastic experts. I will read their bios for those who are on and watching. The way the format is for today, our moderator is Dr. Nancy Kasongo. Our panelists are Dr. Mumba Chalwe and Dr. Dorothy Lombe. It's just a conversation with both of them. If any of you have questions, please drop them in our chat, in our Q&A, or drop them live on Facebook. So why don't we go ahead and get started? I have here Dr. Dorothy Chilambe Lombe. Dr. Dorothy Chilambe Lombe is a clinical oncologist with subspecialization in brachytherapy from Zambia. Her area of expertise is gynecological and genitourinary malignancies, as well as Kaposi sarcoma. She's a fellow of the College of Radiation Oncologists, Colleges of Medicine, South Africa, and holds a Master of Medicine degree in Radiation Oncology from Stellenbosch University in South Africa. She serves as the chair of the cervical cancer subcommittee of the National Cancer Technical Working Group in Zambia, and is a member of the Resource Stratified Guidelines Advisory Group for the American Society of Clinical Oncology. In establishing an independent research career, her interests include application of ultrasound-based imaging in the radiotherapy process for resource-limited environments and immunogenic effect of radiotherapy in advanced cancers. She's the coordinator of the CDH training program and specializes in administering chemotherapy and radiation therapy to cancer patients. She's the recipient of the American Society of Clinical Oncology, ASCO, Conquer Cancer International Development and Education Award in 2016, and International Development and Education Award, IDEA, in 2018, and a Long Life International Fellowship. She's a member of ASCO's Resource Stratified Guideline Advisory Group, as mentioned. She is trained in advances in techniques in brachytherapy, which is a form of treatment in cancer, including prostate cancer. In her spare time, she writes a weekly feature article on cancer for the local Times of Zambia newspaper and volunteers for the Zambian Cancer Society as part of an advocacy work. So thank you for your presence, Dr. Lombe, and very welcome to the program. Dr. Mumba Chalwe. Dr. Mumba Chalwe is a consultant urological surgeon, which is a subspecialty focused on men's health, as well as the urinary systems in both men and women. She's the first female urological surgeon in Zambia. She holds a Master's of Medicine in Urology and has vast experience working in both local and international healthcare settings. Dr. Chalwe's clinical experience spans over the last 10 years and has ranged from day-to-day patient care, surgery, as well as teaching in the academic hospital setting. Her current practice is Ndola Teaching Hospital, Zambia. She's an international speaker with presentations at the World Congress of Surgeons, Incision, and World Leaders in Global Health. She has served as a judge for the Global Surgical Training and presented at a TED Talk on productivity lessons for the operating room. She's a fellow of the College of Surgeons of East, Central, and Southern Africa, COSEXA, and an associate fellow of the American College of Surgeons. So welcome, Dr. Chalwe. So as we were preparing this, I'm just going to share just a few clips, before we get started into the conversation. So as we do these monthly sessions, we sometimes get some feedback, and I thought the feedback we received for the prostate cancer was very, very interesting. So I'm going to read about 3 or 4 responses that we received, and hopefully Dr. Lombe and Dr. Chalwe can talk about this. So one of the first responses we received was, I saw this and was wondering why there was no male on board since they were going to be talking about the prostate. Then the other one, great stuff, the organizers could have done better by being gender balanced, especially that the subject matter is masculine. Couldn't you find one male specialist on the panel? And then the other one was nice, but why only women are talking about our prostate? It's not fair. I could go on with some of the other ones, but I thought some of these responses were amusing. So I'm hoping that this is something you could both touch on. And, I used a lot of big words when describing your bio. So hopefully you'll be able to touch on what all those big words mean for our audience. We've got a very diverse audience. I will now step out of the picture and, transfer the conversation over to our moderator, Dr. Nancy Kasongo. Thank you both for your time. Very much appreciated.
Thank you very much, Dr. Akwi, for that wonderful introduction. Today's session is really exciting for all of us. And one thing we should know is that the month of September is actually Prostate Cancer Awareness Month. And awareness on prostate cancer is very important because it leads to early detection and treatment of prostate cancer. And so today is also really exciting. I think one of the comments that I found to be hilarious was that today's panel was actually coined as the women with prostates. That was a comment from one of the followers. So we're going to dive into today's topic. Maybe we'll just go over Dr. Dorothy Lombe. Maybe you could unmute yourself and just tell us maybe who is a clinical oncologist.
Yeah, thank you very much, Nancy, and thank you very much, Momba, for being part of the panel as well. I'm really happy to be sharing this afternoon with everyone who's joined the conversation as well. Prostate cancer is very close to my heart, and I really think we shouldn't be losing as many men as we do from prostate cancer. So to answer some of those comments as to why it's an all-women panel, well, I'll explain by maybe starting with Nancy's question, what a clinical oncologist is. A clinical oncologist is a doctor who specializes in delivering radiotherapy and chemotherapy. And the reason why you have me as one of the clinical oncologists here speaking to you is that I'm specialized in brachytherapy, which is an even more advanced form of delivering radiotherapy, and one of the top cancers that is cured by this brachytherapy is prostate cancer. And what brachytherapy actually does is preserve a lot of normal function, so the side effects of treatment are actually minimalized by brachytherapy, which is one of the things that a clinical oncologist can do.
All right. Thank you so much, Dr. Lombe. I think we just lost Dr. Chalwe there, but I think she'll be joining in shortly. Maybe we could just dive into today's topic, which is prostate cancer. Maybe Dr. Lombe, you could just tell us, what is prostate cancer? This prostate everyone keeps talking about today.
Exactly. So rightfully so, the prostate gland is unique to men. Only men have a prostate. And sometimes the cells of this prostate can undergo a transformation where they become cancerous. And that means that they start multiplying uncontrollably. So basically, prostate cancer is the uncontrolled multiplication of cells of the prostate. And this is typically of men of an older age, but in African-American men, it's actually, or African or men of African descent, it's known that they get prostate cancer at a much earlier age.
All right, then into looking at the incidence rates or the numbers, like how is Zambia doing in terms of the numbers of prostate cancer in comparison to other countries in Africa and abroad?
That's a very important question. And I think I'm going to approach this question in a way that won't undermine the importance of prostate cancer in Zambia. When you look at the most prevalent cancers in Zambia, prostate cancer is not the tops as in other countries, basically because, as I've said, it's a cancer of older men. However, the life expectancy in Zambia is lower. Therefore, when you look at all the statistics, you'll find that less men would have lived long enough to add to the statistics of prostate cancer. However, at the Cancer Diseases Hospital, it actually ranks as the third most common cancer, cervical cancer being the most common, followed by breast, and prostate cancer is the most common. Of course, we've got Kaposi sarcoma, which is HIV related, but when you talk about the non-HIV related cancers and skin cancers, prostate cancer ranks number 3.
Right.
Sorry, Nancy, what I would want to say very quickly is that the prostate cancer that we see in this side of the world is actually usually locally advanced, which is in contrast to the type of prostate cancer we see in developed countries. And that's where we're hoping to go, because men shouldn't be dying from prostate cancer.
All right. Good to have you back, Dr. Chalwe. So we were just going over what prostate cancer is. And I think we could now get back to you because the next question was actually for you. So Dr. Chalwe, could you please tell us, like, who is a urologist?
So a urologist is a doctor that deals with the genitourinary system. Genitourinary system ranges from the kidney, the bladder, the prostate, all the way down to the external genitalia. In men, this happens to be their reproductive system as well. So a urologist will take care of that as well. In women, we only deal with the kidney, the bladder, the ureters, the whole urinary tract.
All right. I hope this answers the question as to why you as a woman are speaking on this panel today.
Yeah.
All right. So we'll get to our next question. So how can, Dr. Chalwe, maybe you could answer this one for us. How can one tell that they have prostate cancer?
Prostate cancer is quite interesting in that the symptomatology or the symptoms are there's a wide spectrum, starting with no symptoms at all. So it's known as an indolent cancer where you won't really see an external, manifestation like a lump or a mass. It's something that you're not going to see overtly. When it is symptomatic, you have patients who have either predominantly andrological symptoms. These are symptoms related to the male reproductive system and sexual health, or urological symptoms. These are predominantly urine symptoms. So difficulty urinating, changes in the stream of urine, things like that. Those are urological symptoms. Andrological symptoms may be things like impotence or erectile dysfunction, bloody ejaculate, and things like that, andrological symptoms. Then, of course, you have another group of patients like Dr. Lombe alluded to. We do get a lot of locally advanced and advanced prostate cancer. So those may come with systematic symptoms where they may present with a backache, bone pain, and symptoms of advanced disease.
All right. Okay. Having mentioned that it's an indolent type of disease, so can we go into screening? Like in the Zambian setting, how can we make sure that we catch it early? What can we do? Dr.
Is that
Lombe,
to me or
maybe you
Dr.
could
Lombe? I think
start.
I'd like Dr. Lombe to touch on this because
Yeah, I think what Mumba said, or to add to what has already been discussed in terms of the symptomatology of prostate cancer, it's also non-specific. I think you agree with me, right, Dr. Chalwe? So other sorts of normal benign problems will manifest themselves exactly the way prostate cancer would. And it is befitting to talk about screening after you've explained that, because there really is no way of finding prostate cancer early. And the word screening actually means that you want to discover a disease before it shows itself. So what has happened over the years in medicine is that for certain conditions, and then in particular, when we speak about cancer, there are about 5 cancers that screening is shown to be beneficial. So it's not every cancer that you need to go for a whole body scan to look for a dot, because we will find dots in your body. But there are certain cancers where it has been proven that if we find it early, the benefit, both economic, the burden on the health system, the burden on the productivity of the country, if we find it early, all that actually adds to an overall benefit for humankind, so to say. So screening for prostate cancer is usually done by, first of all, a very simple test. So As Dr. Shalwe mentioned, you won't see a lump outside because the prostate is inside. However, if someone like Dr. Chalwe puts her finger by medical examination into your rectum, she will be able to feel a lump that you may have not noted is actually causing you problems. So the most native, or, you know, I don't want to say primitive, but the basics, like, someone, basic, yes, it's not primitive at all because it's basic and it's necessary and we should continue using this, is by medical exam by a qualified professional. So that examination is the first screening test and it's called a digital rectal exam. The next screening method is by blood test. And that is getting a lot of debate around the world but I think if Zambia itself, a blood test called a PSA test, Zambia itself has adopted the fact that we do screen by PSA test, but I know we have a very knowledgeable audience and they probably read. Some countries don't employ that. And what is the reason behind it? PSA can be non-specific. For example, in diabetics, the PSA could be raised above the normal range. Or if a man has had sexual intercourse just before having his PSA measured, you'll also have a raised PSA. Or if you have an infection,
a UTI.
A UTI.
Or if you ride a bicycle too vigorously.
There you go. If you exactly. And that is why there's always an emphasis. It's not just about walking into a lab and saying, hey, I want a full cancer screen. It actually has to be done by somebody who will know what to do when they find that raised PSA. So to summarize my contribution on screening, there are two main basic tests of screening, and the first method is digital rectal exam, and the second is a prostate-specific antigen test, PSA blood test. Yeah.
All right, Dr. Chalwe, would you like to add anything to that?
Just to say that PSA as a blood test is specific to the prostate, but not specific to cancer, which means all that PSA is telling you is that you have a prostate, okay? And it's not necessarily indicating that you have cancer or not. So it needs to be interpreted in context, exactly. Which is why it should be, I've had cases where PSA is almost zero, but someone actually does have a prostate cancer. And these are special cases which people need to be aware of, that it should always be taken in context and not as a standalone kind of self-screening tool.
Right. Okay, so in line with screening, as we are aware, like when we talk about female cancers, there's a lot of word out there. So do we have any programs for the men?
Not yet, but we're working on it. We don't have a standardized national program, but I can assure you that the next national cancer strategic plan will have prostate cancer screening. However, for a long time, you know, general practitioners and urologists themselves have been attending to this, and we have been educating, and we do raise awareness. But all we're saying is that there's not a standardized national guideline that people can refer to out of, you know, that is available currently.
All right. So if you just joined in this webinar, we're talking about prostate cancer, and we just discussed screening. So two of the ways you can get screened for prostate cancer is by having a clinical examination, which is the digital rectal examination. Dr. Chalwe and Dr. Lombe, maybe you could just tell them, are there any adverse effects, any complications of undergoing a digital rectal exam? Because it seems like maybe the men could be afraid of going for screening.
Dr. Chalwe, you go first.
Well, there are no known adverse effects of a medical exam. It's quite a friendly examination. It takes not more than 2 minutes. If it's done by someone who actually knows what they're doing, it's quite comfortable. And the advantage is that's your full prostate exam. So if you do have anything else going on, it can easily be detected. As for the PSA, the PSA, I think, in my experience, has been a source of psychological stress when taken out of context. So if you as a person decide, I'm going to get routine PSAs, you may give yourself that psychological stress of thinking this, that, and the other, not knowing the context of your PSA test. So that might be an adverse effect, as it were. But otherwise, these are pretty standard doctor's office procedures.
All right. Okay, so men should not fear to go. It's just a simple clinical exam to help you know whether you're at risk of prostate cancer or not. Okay, so there's a question.
Can I just add, Nancy? Can
Yes?
I just add? And Zambia does have male urologists.
Yes.
As a side. So just feel confident that you do have the option of a male urologist if you so please. So
All right, so there's a question. I don't know whether Dr. Chalwe or Dr. Lombe will answer. So one of our webinar attendees is asking, what about the use of transrectal ultrasound as a screening tool?
So the transrectal ultrasound is the next step in the screening process. So, you know, if I can go into the nitty gritty of how the PSA is then handled if it's raised. So when a man goes for a PSA test, which is a blood test, and it is found to be raised, of course, the history will be taken. You know, we've spoken about diabetes, we've spoken about UTIs, we've spoken about sexual intercourse just before the test, and so on and so forth. So if all those things are addressed and the lab investigations around that are done, and it is felt that the PSA may be pointing to prostate cancer, an ultrasound of the prostate will help us see whether there is any growth in the prostate that will point to the prostate cancer. And that, if you see a lesion, you would then want to conduct a biopsy directed to that lesion on the ultrasound.
Right, Dr. Chalwe, anything, or we can move on to the next question?
It's pretty standard, actually, the transrectal ultrasound. It's pretty standard in most centers that you go. You will get a ultrasound guided. The yield from biopsies has been found to be better than doing a blind biopsy, because you can direct your biopsy at the suspicious area of the prostate, because it has many different areas. So you want to make sure you're kind of directing in the area of interest.
Right.
So it's not a screening tool, it's a diagnostic tool.
Diagnostic tool, yes.
All right. Okay, so are there any risk factors? Like, how would you know that you're at risk of having prostate cancer?
Well, the risk factors are age-related primarily. Prostate cancer has been found to be age-related. There has been some links to a familial mode of presence of prostate cancer, wherein if someone has a first-degree relative, an uncle, a father, a brother, with a history of prostate cancer, then this person will probably need to be thinking about getting themselves checked sooner than later. Other risk factors, Dr. Lombe, have I missed out? I'm not sure I can pin anything on diet. The jury is kind of out when it comes to dietary kind of associations. But maybe our friends in oncology might have more insights into other risk factors. But those are the main common.
Yeah, so I mean, the risk factors for prostate cancer are common to a lot of cancers or conditions around certain age of men. And I always say, when you tackle them, then you're basically getting rid of your diabetes, your heart disease, your colon cancer, all in one package, and your prostate cancer. So as Dr. Chalwe has mentioned, you know, there's obviously the non-modifiable risk factors. This means that there's really nothing you can do about it because it's going to happen. And this would be familial inheritance. So on your blueprint or your DNA, you have a mistake that has happened through the generations, and it comes out as a phenotype in you as you age. Age itself, as it said, is non-modifiable. You're going to get older, and some of us oncologists say if someone lives long enough, eventually they will get prostate cancer. The other modifiable risk factors are actually diet, and it's been proven that a diet rich in vegetables actually reduces your chances of getting prostate cancer. So basically your antioxidants and everything, so fruits and vegetables. Also, it's been found that exercise is also directed to reducing your risk factors for prostate cancer. Low fat diet, low red meat diet. And so as you can see, basically anything that will work to build your immunity to a higher point will work to reduce your chances of prostate cancer, hypertension, diabetes, colon cancer, high cholesterol. So you're going to beat a lot of things by reducing those risk factors.
Right. That seems very involving. You have to work really hard to prevent all these conditions.
Nancy, there's actually an interesting, I just remembered as Dr. Lombe was talking, that some studies were done that linked sexual activity to being prostatoprotective.
Mm-hmm.
So, yes. Mm-hmm. So, of course, without forgetting the basic principles of safe sex, of sticking to one sexual partner. Those are the basics we all know. But it has been shown that it's quite an old study. I haven't had a chance to relook at it recently, but men who were sexually active up to the age of 35 mm-hmm. were found to have less prostate cancer as they got older. So I think it's something interesting. I've always found that very interesting. And I just thought to put it out there.
Exactly. Right. Especially that you're an andrologist.
Yes.
We hope we don't get misquoted.
But
important.
Yes, it's very important. And I think I love the way you really underlined the fact that it's not promiscuous sexual activity that leads
safe.
that leads to a reduced risk of prostate cancer. I do get you, Dr. Chalo, because it comes up every so often. And it's usually a front page article saying, listen, prostate cancer is reduced by having more sex. And yes, there's that association of lower prostate cancer in men whose sexual activity is high, but it's safe sex that you need to understand will prolong your life and not promiscuous.
The other one will kill you.
The other one will kill you, definitely.
All right. Okay, so I have another question. So let's say a man goes for screening and he does his digital rectal exam and it comes out okay. So how often, when should he go back for another test, or is one test enough?
Every year. So screening for prostate cancer is yearly.
Oh. Mm-hmm. All right. Well, men have a lot of work to do now.
Yeah. Not really. It's once in 12 months.
Once in 12 months. And honestly speaking, as Dr. Shalwe alluded to it, the digital rectal exam, I think, is just taken as, because as human beings, those are parts of our bodies that we just don't typically, touch or associate anything with other than, natural expulsion of waste matter. But the point is, in the correct hands, digital rectal exam is actually it's not uncomfortable, but to an extent that someone would never want to come out. Just so that people know, there is actually a thing called prostatic massage, which most men actually find relief from. So the stigma around the digital rectal exam really needs to, to go down and to end, because it is not an uncomfortable exam.
All right. Yeah, I do get there's a lot of stigma, especially when we have like really elderly men who are like grandfathers or parents, and then they find
Did we lose Nancy?
Yeah.
it's really all right. So we'll now move on. So how do you
I think we lost Nancy.
Yeah.
All right, not a problem. I will take over as Nancy tries to find her way back. So actually, this has been a very interesting conversation, but you guys have been using some big words. And so before we get into some of the other questions, please, what is ejaculate? What is indolent? What exactly does PSA stand for? Because you have to remember, some people watching may not necessarily understand. So maybe you can kind of define some of those words.
I'll define
And then
indolent.
someone mentioned bloody ejaculate, and the question is, what is ejaculate? So if you can explain some of those words, and then we'll go on to some of the next questions.
Okay, so bloody ejaculate, we have two types of excretion or secretion that come out of the male urethra. One would be urine, which we all know what urine is. And then another would be ejaculate. This is during sexual intercourse. A man will ejaculate when he reaches climax. So in advanced cancers, or actually it depends on the localization of the prostate cancer itself. If it's going into the urethra, encroaching inside, you'll find that some men will see blood in their ejaculate. And this is one of the first, it's not painful. It's not, it's something that most people will ignore. But if you take a good history, you find that several years ago, or over time, someone has had what's known as hematospermia, that is blood in their ejaculate. So it's important for men and women to notice what's going on. In fact, even blood in your urine is something that you should immediately take note of.
And then the other word, indolent, if you could explain what indolent means, and then maybe, just say or spell out what the abbreviation PSA stands for. And Dr. Kasson goes on, so I'll go back to the background as you answer those two questions.
Okay. Dr. Lombe, was that you who brought the PSA story?
Oh, yeah. So I'm so sorry about that. I actually thought I had, spelled it out. It's prostate specific antigen. So it's just basically describing the chemical, a chemical that is produced by the prostate cells. And indolent actually means that something isn't so aggressive or active. It's sleeping, basically. It's a sleepy disease. So that's what those big words mean. Welcome back, Nancy.
all right, thank you. I hope you
Nancy.
didn't really, I was hoping you're not at the end of the whole show.
No, we haven't gone too far.
All right. So we were talking about confirming prostate cancer. Like, how does one get a confirmation that they actually have prostate cancer?
Yes. So the diagnostic part. So usually the urologists are our partners. We kind of submit to them to make sure they deliver our patients to us. And hopefully they don't keep them by just doing a prostatectomy, which is a very good option for
certain cases.
For certain cases that obviously we'll speak about this afternoon. But diagnosis is basically when someone either presents through the screening program or through symptoms. We spoke about the ultrasound being put in the prostate to visualize where that could be coming from, and biopsies, which are basically a method using a needle through the rectum into the prostate, and sampling the tissue of the prostate are taken. All this is done by people who are actually trained. It's very, very important because this particular biopsy is actually not to be taken lightly. Getting to the decision of actually undertaking a prostate biopsy is not at the first presentation of symptoms or a raised PSA, because as much as we advocate for things, we actually do also realize that these things may have adverse effects. And one of those large ones is infection by biopsy. So you need to actually have someone who is qualified to take that biopsy from the prostate.
Right. Anything, Dr. Chalwe?
Not really. With prostate cancer, it's really a team sport. So as urologists, we actually rely on the GPs, and we hope that when a patient comes to you more than once with UTI symptoms, an elderly gentleman who comes with a limp, that the GPs will then take it a step further. And because the presentation, like we said, can be quite vague. It can be a presentation of a urinary tract infection. It can present as just about anything. So we also rely on the primary care physicians and the general practitioners, and all the way down to the district level, the primary healthcare level. We really rely on that heavily to make our diagnosis, because by the time they're coming to us, we're already heading towards thinking the oncologists, treatment. So we really heavily rely on the community to sort of channel patients towards us so that we can do a more rigorous assessment and end up with a diagnosis and a treatment plan that is tailored to that particular patient in that particular case. No two prostate cancer patients are the same. So we have to tailor it, and we have to make a plan and talk. We have talks with Dr. Lombe all the time, long talks about
very long
every single patient. So from diagnosis, are we going to do the biopsy? What if we find a cancer? What then do we do? So it's quite a well thought out and really thorough process.
Right. That is really informative. So if you're just joining in, we're talking about prostate cancer. So we have described what it is and who is at risk of it and how you screen. And now we're moving over to treatment. So after somebody is given the diagnosis or has the diagnosis of prostate cancer, what happens next? What options of treatment are there?
Refer to Dr. Lombe.
So there's something very nice that I liked about what Dr. Chalwe said. She said prostate cancer management is a team sport.
It's a team sport.
It is a team sport. You actually have to have the urologist involved. You have to have your oncologist involved, and ideally the GP who is closer to the patient.
Yes.
Yes, exactly. So first of all, when we talk about the options of treatment, I'm going to say something that is going to shock everyone, and it's always come up, and you never know what to say. The option of treatment of a cancer is doing nothing. Like that usually doesn't sit very well. That usually doesn't sit very well. So for prostate cancer, you have about 4 options of treatment. There's what we say doing nothing for a long time and doing nothing for a while. So that doing nothing for a long time is actually called watchful waiting, and doing nothing for a little while is called active surveillance. And then you've got the hardcore interventional methods, that surgery. Surgery is one of the treatments where you actually remove the whole prostate. And again, this is not for all the types of prostate cancer. The specific cancers that works very well for, and specific age groups as well. It's not every age group that you would want to recommend for surgery. And then the last part where we come in is radiotherapy, and for some patients, chemotherapy, and we also use hormone therapy as a modality. But those are the last spectrum of the oncological interventions. Yeah. So let me speak a little bit about the watchful waiting, which is what people must understand about prostate cancer. Because here you are, you're saying, okay, I've listened to Dr.
I've got a
Chalo and
cancer.
Dr. Fonde, you know, I'm taking my father for screening, you know, and then you find his PSA is raised, and then the doctors tell you they're not going to do anything. What is all that about? So remember, Dr. Akwi reminded us to speak about the word indolent. This means that there are certain types of prostate cancer, and I'm going to say certain types of prostate cancer that do not require active intervention because the risk of them actually causing death of the individual is much, much less than the other conditions that the patient has. So I'll pause here and I'll let Dr. Chalo also chip in. Have we lost Dr. Chalo?
Dr. Chalo, are you there? Okay, I'm sure she'll join in shortly.
Okay.
Yeah, so you brought
so,
in some really interesting things. So now I'm sure a lot of people are wondering, like, why am I going through everything if you're going to talk about doing nothing a little while?
yeah.
Yeah, I'm sure everyone wanted to know, like, I know initially you mentioned something to do with brachytherapy. Maybe you could talk a bit, like, what is that really?
Mm-hmm. So when cancer, basically the prostate cancer is divided into low risk, intermediate risk, and high risk. And for the low risk patients, those are the ones I'm saying they fall into the category where we don't have to do anything for a while. And we basically watch them and see how they progress and match their risk factors for death against the prostate cancer. In intermediate risk and high risk, for those type of cancers, we have to intervene. And brachytherapy comes in the fact that it's a very conformal type of treatment and it's able to kill the cancer very effectively. And we do this by two methods. The word brachytherapy, actually, let me step back. The word brachytherapy means that you're putting the source of radiation, which kills the cancer, right next to the cancer. There's another form of radiation called external beam radiation, and this comes from the outside. So I'm sure, you know, you're asking me about brachytherapy because that's what I specialize in. I'm a brachytherapist. So we put the source of radiation right in the prostate, and most men like this because one, they don't have to undergo a whole operation that that will, you know, cause problems like incontinence problems. And incontinence means basically they're not able to hold their urine and they dribble and so on. I mean, that's one of the reasons that people don't want to undergo treatment. So brachytherapy is very good with that. Number two, they're able to preserve their sexual function when they undergo brachytherapy. So that's why most men also prefer the option of brachy, and that's where the age factor comes in when you're choosing treatment options for a patient. So the way how we deliver brachytherapy, you could either use seeds, which are permanent implants. So a man comes to us and there's specific radioactive material that we call seeds. And we have specific equipment that we use to place these seeds in the prostate of the man and deliver the radiation safely to achieve what we want to do, which is cure. The second type of brachytherapy that we are also able to do here in Zambia would be high dose rate radiation. So that would be the temporal implant of radiation in the prostate. So we are currently not offering brachytherapy at Cancer Diseases Hospital just because of a few equipment challenges. But for the seed implants, that is not offered at all in Zambia because it requires a lot of other logistic problems.
All right, great to have you back, Dr. Chalwe. So we're still.
I didn't realize I was off.
Oh no, I hope you didn't go on explaining to an audience that wasn't there.
Okay.
All right, so we're still talking about the treatment options for prostate cancer. And I've gotten a new question from Chikwe Mwanza. I think one of the treatment methods that was mentioned was surgical. So a question from Chikwe is, does prostatectomy reduce a man's fertility? Because the prostate produces the seminal coagulum, which makes it easy for sperm to move. So Dr. Chalwe, over to you.
Okay, so I left a train of thought when I thought I was off or on. I just wanted to add to, I don't know if Dr. Lombe mentioned before I answer the question, that whenever we're thinking of treating prostate cancer, like we said, we have to look at the patient factors. We have to look at the disease factors. So it's critically important. And a lot of times after the screening and diagnostic process, a lot of patients expect that boom, boom, I've been diagnosed, let's take the prostate out. So the staging process is also a very important process for us as doctors and as surgeons. And I'm sure you will agree with me, Dr. Lombe, that for either one of the treatment modalities, we need to have a stage, we need to have a grade, we need to know the patient's functional status. We need so many things will determine what treatment we give. As urologists, our two primary concerns are, in no particular order, sexual function and renal function. That was just a joke. Renal function is definitely more important. So our concern as urologists is always we must save life. And while we are doing that, if we can preserve quality of life, then we do that as well. By quality of life, we're looking at now issues of continence. We're looking at issues of erectile function and
All right. I think we've lost Dr. Chalwe again. Okay, so I'm just trying to check if we still have any more questions. Oh, okay, there she is.
Yeah, so
we lost you, right?
So when we're looking at surgical management and any form of treatment we're going to take, that's what we're looking at. When it comes to surgery, it has become quite advanced. In certain parts of the world, we go as far as using robots just to increase the precision and accuracy to preserve sexual function and to preserve continence. Okay, and I must emphasize again, this also depends on the disease, the extent of the disease, because we will not sacrifice cancer clearance over, say, continence and other functions. So you do want to save your life and give you a good quality of life. Then prostatectomy. Prostatectomy, we need to understand that there's different types of prostatectomy. So there's
All right.
okay.
We
So are you there, Nancy?
Oh, yes, we're still here.
Yeah, so you have to understand that in terms of prostatectomy, those are the two types of prostatectomy that we do. And the sexual function is usually preserved. There will be some side effects, which we discuss with the patient, depending on the patient factors before we go in. Then as for the sperm coagulum, the prostate produces a component of the semen. It doesn't produce the entire semen. So there's many other components of the seminal fluid that are produced in the seminal vesicles, in the other glands in the male reproductive system. It's not solely the prostate's job. So in younger men, especially men in their 50s, we do try as much as possible to preserve what we can preserve and give the patient a cancer-free and good quality of life. I keep emphasizing we must achieve the cancer-free margins, you know, the tumor-free margins, make sure that we're doing something that's curative, getting rid of the cancer, as well as preserving their function, especially in the younger men, the 50s. Some cancers are diagnosed as early as 45. So we really want to make sure that we're doing the best for the patient. That was a mouthful.
Right. Dr. Chalo, I think we lost you when you talked about the types of prostatectomy. Maybe you could just repeat that.
So, like I said, prostatectomy needs to be understood in a certain way. We do prostatectomies for different conditions. So when it comes to a cancer prostatectomy, it's very different from a non-cancer prostatectomy. So I think that's as simply as we can put it. There's different ways of doing each of these, but there's basically two: a cancer prostatectomy and a non-cancer prostatectomy.
All right. Dr. Lambe, is there anything you'd like to contribute? I saw you wanted to say something.
Yeah, no. Actually, what I want to underline is what Dr. Shalwe has been talking about. As a urologist, as a clinical oncologist, anybody, any professional involved in cancer care has a goal of, one, getting rid of the cancer, two, ensuring a quality of life that matches the benefit of whatever intervention you are about to deliver. So that is very important for other health professionals working outside cancer care and patients and their caregivers to understand. I mean, for most caregivers who are also important in managing a prostate cancer patient, for example, when we're talking about treatment, their only concern is to get rid of whatever is threatening the life of this person I love. And in their mind, if they think that surgery is ablative, then you go for it. You know, in their mind, if we manage to convince them that radiation could ablate it, they want us to go for it, even if the radiation will be uncomfortable for the patient because it's not appropriate for the amount of time we estimate they have left, you know, or matches their age, or how much damage the treatment could cause in the long run. So when you talk about treatments, you know, it would be naive of us to think we can exhaust all these treatment options, explaining each and everything, because as you've noted from what we're saying, it's a complex cancer where you take into account a lot of things. What would be more important to carry away from this conversation would be the principles of those things. We want to get rid of the cancer. We want to ensure a quality of life, and we want to make sure we do something that will match those two.
All right. And anyway, moving on from the treatments, there's also a condition that is common in elderly men called benign prostate hyperplasia. Maybe you could define what that is and how different it is from prostate cancer.
Okay, I was just getting rid of little boys who want to be on the Zoom call.
Maybe that's why you're also qualified to talk about prostate, because you've got a train of little boys behind you.
Yeah, so BPH is basically the bread and butter of every urologist. We treat it, we love to treat it because it's a benign disease. What does benign mean? This means it's not a cancer, and there are several treatment options. It's important for me to outline that, you know, from studies, it has been shown that every man, if we were to check every single man above 50, we would find that their prostate is enlarged. So it's almost, if I can say, a natural occurrence. Okay, so with age, the prostate will increase in size. So it's not every enlarged prostate that requires intervention. That's number one. That's the first. Is that it's a primary care condition. A lot of these patients go to their primary care physician with the symptoms of an enlarged prostate. So it's very common. It's almost a given as a man ages that their prostate will enlarge. The only concern is what level of symptoms they have and how that's affecting their quality of life. Okay, so where we come in is, I think you asked the question in the beginning, what's the difference between urologists, urological surgeons? It depends on which country you're in. The urologists, in some countries, urologists are the physicians who sit in offices and deal with things like BPH, where it can be treated using medical therapy. That is non-interventional. We just use medicine. Then in those same countries, you have the urological surgeons who now, they also treat things medically, but they are more inclined towards surgical interventions. In Zambia, there's not much of a distinction. I just like to use it just to, to tell people that they have lots of options. They do have, the option of surgical management of their condition as well. So yeah, in a nutshell, that's basically what it is. It's a non-life-threatening, benign, non-cancer condition, which is very common and is very treatable, either medically or surgically. It can be handled by your primary care physician, by your general practitioner, but it's always good to get some urological input at the beginning, just to make sure you don't have risks of complications, because BPH can get complicated and can potentially lead to life-threatening things like renal failure. So it's just important to keep that in the back of your mind, that although it's benign, ignoring it can lead to serious consequences.
Right. Thank you so much for that. So we have a question from Emmanuel Kaka. This is from Facebook. Emmanuel, thank you so much for joining in. So before I ask the question, anyway, his question is to do with hormonal therapy. I'm not sure. Did you mention hormonal therapy as a treatment option for prostate cancer?
Yes.
Dr. All right. Yes. So this one's for you, Dr. Lombe. So the question from Emmanuel is, you talked about hormonal therapy as a treatment modality. So can prostate cancer be caused by another hormone producing cancer in the body?
A very interesting train of thought. Very good question. Let me clarify that. So actually, prostate cancer is fed by the hormone testosterone. And testosterone is naturally produced in the testicles and a very small amount in the suprarenal glands of a man. So hormonal therapy is actually directed at competition with the hormones that are being produced in the body, or to block those receptors that will feed that cancer. What I'm trying to say to break it down further is that the cancer cells have got certain receptors that allow them to keep on growing and give birth to more cancer cells. So what you want to do is to stop feeding those cancer cells. So there are two options. You stop the food, which is the testosterone hormone, and that can be done surgically by Dr. Chalwe, where the testicles are actually removed. I think we'll get back to that because it's a very important aspect from the psychological point of view of treating prostate cancer. Another way of doing exactly the same thing is by using medical, compounds. So you have some that actually block only some of the receptors, and you have some that imitate the surgical procedure. And those are the hormones or anti-hormones that we speak about. And this is blanketly called androgen deprivation therapy, ADT, in the treatment of prostate cancer. So maybe Dr. Chalwe, just to go on further, if Nancy, you would allow me, because I think this is an important question. When you perform an orchidectomy, which is the removal of testicles, maybe could you explain that procedure to the audience. What happens? How does the person look afterwards? How complex is that procedure?
So it's important to understand that androgen deprivation therapy, that's hormone manipulation therapy or using hormone therapy as part of prostate cancer treatment, is one of the modalities which we discuss extensively with patients who might benefit from that. It's not for everyone. And it's not like we routinely, hi, you've got prostate cancer, let's castrate.
Exactly.
We really do have, because we understand the psychological impact it has, as well as the physiological impact of removing the source of testosterone altogether. Previously, historically, we used to do something that was quite radical, and a lot of men were not happy with the outcomes and were not happy with the cosmetic kind of appearance of the scrotum afterwards. So urology has advanced, and we are offering very cosmetic procedures where we're not, people imagine it to be a very traumatizing, painful experience. It's painless, absolutely painless. It can be done in an office setting, so you don't need to sleep in the hospital. It's very comfortable. And we do offer a cosmetic kind of surgery where we open the testicles themselves and go and produce the testicle producing part of the testicle. That sounded like a bit of a riddle, but I'll say that again. So we don't go and arbitrarily cut off everything. We actually go in specifically to the part that we're looking for, and we zone in and get just the testosterone producing part. Okay, so we close everything up, and when you look at this person, you cannot tell. Only he would know that this is the procedure that I underwent. And I find in my practice, a lot of patients are quite happy with that. And it just shows that medicine is advancing, and patients value that when they are cared for, even when it's, end stage kind of treatments, because we don't do this routinely. We don't do it for every single person arbitrarily. We have patient selection, and we must talk to the patient. If he wants his family involved, if he wants his spouse involved, we are always open to sit down and have those difficult conversations and offer support. So one of the ways we do that is by offering a cosmetic kind of procedure where it's not so psychologically traumatizing. When the patient touches, they're still able to feel that, there's something there. They're still able to see. It looks normal. It feels normal. So that goes a long way in dealing with this diagnosis and dealing with the therapy.
All right, Dr. Oh, anyway, you can go ahead, Dr. Lambe.
No, I'm just I'm going to sound like an advertisement for Dr. Chalwe. There's very many happy customers. And it also makes us oncologists very happy, because we know how important when we do recommend for that procedure to be done. It means it's important. It's not trivial in making the recommendation. So to have options where patients are able to still fight cancer and still have, in inverted commas, their dignity, that is very, very important. So
Absolutely.
I was actually very happy when Dr. Chalo told me about this procedure, because it solves a lot of problems from what the patient is imagining as a mutilating intervention. It's actually not. Yeah.
No, it's not.
All right. So we have another question, since we're talking about, okay, yes, we have another question from Facebook. So since prostate cancer arises from the prostate, so should people have a prostatectomy even before they develop prostate cancer? Would you advise people to do that?
No, remember, in our conversation, we have spoken about the fact that the procedures are not without consequence, but you weigh the benefit and you do your best to mitigate the risks of the negative consequences of whatever intervention we do as professionals. So, and I'm sorry for answering on behalf of a surgeon, but as a brachytherapist, that is why most men, when you do offer brachytherapy, prefer it, because the continence issues, the nerve sparing issues, and then they don't get erectile dysfunction. Those are the issues that they want to hear about. So having a prostatectomy is not a solution to never ever getting prostate cancer. Remember, we're saying we will treat your prostate cancer. You will maintain your quality of life up to the extent of, if you come early enough, including your sexual function and maintain your continence till the rest of your life, basically. Yeah. So no, a prostatectomy is not a preventative procedure.
It's unlike a preventative mastectomy, which I know is quite common in the West. So I think maybe that's where that question was coming from. And the prostatectomy is quite invasive. Yeah. So as you consider surgery, even surgeons don't like to cut up everybody. We don't, actually, really? Contrary to common belief. we like to, you know, there's an old saying that says a good surgeon knows how to cut, but an even better surgeon knows when not to cut. So no, I wouldn't say go out on prophylactic and get prophylactic prostatectomies. And the word prostatectomy, like I keep saying, we need to understand it in context. There's a cancer prostatectomy, then there's a non-cancer prostatectomy. So the non-cancer prostatectomy is something we do almost routinely. It's got a very low downtime. You are out of hospital, up and running in 3 to 5 days. Whereas a radical prostatectomy is something completely different. So it needs to be understood in that context, that there's what's known as a simple prostatectomy and there's what's known as a radical. So I wouldn't advise anyone to get either simple or radical for no reason. There's absolutely no reason.
Because even as you say, Dr. Chalwe, for breast cancer, there are very, very particular definitions of which women should get breast cancer. You actually got to have a genetic mutation and of a certain risk of that genetic mutation to be qualified to get the mastectomy in the context of preventative measures.
Prevention.
All right. Okay, so there's another question. I'm assuming maybe one of our attendees or the person that's watching live didn't hear this. So there's a question about sexual activity. Does it increase the risk of getting prostate cancer? Maybe we could just emphasize on what you said about that.
Okay, so I like to quote this study. I wish I had the title, then we could all read it for ourselves. So I think in the early 2000s, there was some evidence to show that 3.3 to about 4 ejaculations a week is prostatoprotective. That is to say, will protect protective against prostate cancer. Now, I say this very cautiously because then it may be misunderstood. And I have to emphasize that, one, it's been shown that this is only prostatoprotective, i.e. protects your prostate up to the age of 35, okay? That's number one. And number two, it's still safe sexual practices. So it's not unsafe, haphazard, and unnecessarily, risky sexual behavior, okay? So it's safe sex, 3 to 4 ejaculations a week, have been shown to be prostatoprotective against prostate cancer.
All right. I hope you got that clear. Safe sex, nothing. Right. I think this will be our last question. Then we'll wrap up. So, Dr. Chalwe, I think this is yours. How is backache linked to prostate cancer as a symptom?
Yeah. Like we alluded to earlier with Dr. Lombe, in our setting in the sub-Saharan Africa and in the generally the global south, it has been found that our prostate cancer is still presenting as advanced disease. What do I mean? Basically, the prostate cancers we see come a bit late. There's late presentation. That's basically what we're saying. And in the late presentation, you'll find that the prostate may have gone to the bones. This is known as metastasis, when a cancer goes from its original site to other sites. I think that's as simple as we can put it. So how is it linked to prostate cancer? Prostate cancer is known to have an affinity for the bone, particularly what's known as the axial spine. So that is the pelvis and the spinal cord. So how this presents is basically back pain, a lower back pain, a hip joint pain. And unfortunately, in a lot of older men, this is considered as part of aging. No, he limps, he moves with a walking stick, and sometimes it's ignored beyond a point which we could have potentially helped the gentleman. So that's how backache is related to prostate cancer. And even then, I will emphasize, even then, there's always something we can do. That's something very peculiar to prostate cancer. There's no, we don't get to the end of the road very quickly, even with metastasis, even with bone pain, even with bone symptoms. We're still able to help, we're still able to intervene and, improve on the symptoms and help out in whatever way we can.
All right. Okay, so we're getting to the very about advanced prostate cancer. Dr. Lombe, maybe you could also add, since you also attend patients when they come seeking services for brachytherapy. So what are the other complications? Like what really happens when prostate cancer becomes advanced?
So, as Dr. Chalwe has said, advanced cancer basically means that the cancer has actually grown out of the original organ. So there could be direct infiltration into the bladder, for example, or you could have had the cancer has spread to the lungs, the bone, the liver. And each case is taken in context of what other comorbidities the patient has. For stage 4 disease, chemotherapy is one of the modalities that has actually got a lot of benefit, more than a 1.5-year benefit if given. And this is not for every cancer. So I really get sad when men who do qualify for chemotherapy don't get chemotherapy because of the myths that surround how we deliver this modality of treatment. So again, just to answer directly in terms of brachytherapy, first of all, brachytherapy service at CDH is yet to be established, and brachytherapy is mostly used for local disease. For patients who have what we call high-risk disease, brachytherapy is used in combination with the other type of radiotherapy, which is external beam radiotherapy, and also long-term androgen deprivation, which we spoke about just a few minutes ago. Yeah.
All right. I think we've gotten to the very end, and we've answered, if not all, of the questions that were had. Maybe any words, Dr. Charlie, that you would have for the men out there? Prostate
Do not
cancer.
be afraid of your urologist. We are the friendliest doctors. Studies have actually shown this. We're the friendliest doctors you'll ever meet. And on a more serious note, prostate cancer, there's so much we can do. Even at advanced stages, there's so much that can be done. Even at the early stages, there's so many options. So I think it's one of those cancers where we have a chance. And these services are available right here in Zambia. You don't need to go too far away from home. And we're able to offer a wide range of options. So it's not the end of the road. And we're happy, you know, we find happiness and joy in helping people. That's why we do this. So we're, you know, our doors are always open. We're always open to assist, to answer questions, even just consulting. Just ask us for our opinion. Ask, what do you think about this? Should I be doing this? Ask. Just feel free to ask. You know, that alone is a step in the right direction. And don't be shy. Just encourage each other and get the truth from professionals. Okay, get a professional opinion. Don't go out there in the community where there might be some misinformation. And it's prostate, not prostrate, gentlemen. So get your prostate checked. You know, you can set up even with your general practitioner, your primary care physician. Just make that step.
All right, Dr. Lombe, over to you.
Yeah, I just want to say thank you to POHER for this opportunity. It was very nice participating and spreading the word, the gospel, as we call it, against cancer. There are a lot of resources out there that are legitimate. I also run a website, dorothylombe.com, that has a lot of information. Every week we publish an article in the Times of Zambia with a lot of information about cancers, and you will catch prostate cancer there as well. So as Dr. Chalwe has said, please make sure you ask the right people so that you get the appropriate help. And I feel we shouldn't be losing men from prostate cancer, because we do have a long window period from when it begins to when a person presents with symptomatic disease. So we hope that our discussion this afternoon has actually encouraged people, and that we'll see more people coming in for their screening.
All right. So it's been really wonderful having this chat with Dr. Chalwe and Dr. Lombe. And I think I would just like to add one thing I learned. You talked about the team player, being a urologist, and over there with Dr. the radiologists and everyone. But then I think we forgot one person that has to be like the number one player, who is the patient. So if you don't go to the hospital, like our team is complete. So let's do this for all the men out there. Let's not lose men to prostate cancer, because the answers are there, the treatments are there, and we're here waiting. Dr. Akwi, over to you.
Thank you. So I do want to echo the sentiments of Dr. Kasongo. Thank you very much, Dr. Lombe. Thank you very much, Dr. Chalwe. You know, we very, very much appreciate your time. You know, this was a great conversation. This, you know, I think, like you mentioned, you know, this is something that, you know, if we have the knowledge, you know, which is what we hoped today, we're able to provide for the audience. So we definitely appreciate what you've shared with us, and hopefully the audience has had a chance to, you know, understand and can reach out to you. As Dr. Lombe mentioned, you know, maybe reach out to our website, dorothylombe.com. And what we're hoping as POHER is to have some of these, you know, monthly sessions where we highlight these different educational, you know, opportunities for learning, where you have the experts. Yes, these were women experts, but these were women who care about your prostate. And that's extremely important. So once again, on behalf of the Pan-African Organization for Health Education and Research, we appreciate your time. And we are honored to have had you on with us today, and look forward to working with you again. And I would just a little shout out for Dr. Lombe. For those who are interested in learning more about the management of prostate cancer, she will be speaking on the Zoom webinar. And I know this because I get the emails, AOTIC, which is, so she didn't tell me to mention this, but I got the email from AOTIC. That's the African Organization for Research and Training in Cancer. So she'll be speaking on Monday. It's going to be a Zoom webinar by, you know, by AOTIC. So visit their website, learn more about prostate cancer. And like they said, it's a team sport. If you have questions, ask your doctor, ask an expert, and that's why we're here. So thank you both for your time. And on behalf of POHER, have a great day, good morning, good afternoon, good evening, wherever everyone is. Have a fantastic day. Thank you.
Bye.
Signing off now.
Thank you.
Thank you.